Okay, well, we're going to get started with the next session. So I am going to let people stream in for one more minute.
With NIMH.
If you can please take your seats, wrap up your conversations.
The elevator speech.
Well, welcome back from our first break. I am really pleased to introduce Dr. Josh Havens, who's an associate clinical professor at the University of Nebraska Medical Center and a clinical pharmacist in the HIV specialty clinic there. We are going to have a case conference on exploring long-acting HIV therapies in practice. It's one of those really promising changes in technology which has been a bear for a lot of Ryan White clinics to get up and going, so I'm really excited for this presentation. So thank you, Dr. Havens, for being here today.
Thanks for that introduction. I feel very fortunate to be here today with all of you in Louisville.
Got it. Close enough.
I knew I was going to do that. I have some panelists here up here with me. I'll have them introduce themselves real quick. Go ahead, guys.
Okay, so I'm Mike Saag, and we've already met. And you know how to say Louisville now. Yeah, I think it's
I'm Hyman Scott. I'm from the San Francisco Department of Public Health.
Carolyn Chu, also from San Francisco and Department of Family and Community Medicine.
All right. So these are my disclosures. So the plan for today is really, I'm going to give a relatively quick overview of long-acting injectables. Well, actually, mostly long-acting injectables. I'll touch a little bit on just long-acting drugs in general for both HIV treatment and prevention. But I really want to get through that because there's some fun cases that I have built towards the back that we can kind of talk through. Some of it is things that probably most of you may already know. Some of it are things that even myself, I don't really know what to do, really. So my hope is that we can get the panelists involved because I would love to hear what they think on a couple of these cases. And in doing that, we're going to talk about just some of the clinical challenges that we currently have with long-acting drugs, the implementation challenges, and how best to manage folks, just generally speaking. I will throw out a quick disclaimer that I am going to spend most of my time on cabrolpivirine. And I did that because Dr. Scott's going to be talking on Tuesday, I believe, which is going to have a heavy emphasis on CAB-LA for PrEP. So let's get into it. If I can get it to work. Oop. Go back. Okay. First Slido poll. Here we go. Or Sluggo. All right, how many patients have you managed with long-acting agents for HIV treatment or prevention?
I forgot to mention the QR code's also on the back of your name badge, so. Yeah.
No.
All right. Let's see what we got here. Okay. All right. All right, so we all know we've back when I started in HIV about a decade ago. I mean, I was a little bit late to the game compared to some folks, but we've really progressed in a way to where we're using a lot of pills to now some folks get long-acting treatments on an every 2-month schedule, and so it's clearly our progression is to continue on that path forward. So on the left, you'll see kind of the progression of our HIV landscape, the years of what has progressed along with time. And then on the right side, you'll see some of the newer drugs that are currently being studied right now, and I think Dr. Gandhi will talk about some of these on Tuesday in the last session. But the point is that we have a lot of new agents coming forward. What do we know about our current agents right now? Well, there's really 4 different ones at the moment. They're very efficacious, both for treatment and prevention. I'm not going to belabor all this because I'm sure most of you know it, but we have cabopivirine for treatment. Right now, lenacapavir's current indication is mostly as an adjunct agent for treatment of HIV onto an optimized backbone regimen. And then we have cabotegravir LA for PrEP and lenacapavir probably most likely next year. But they all work very well. There we go. All right, so patients and providers, I think this is really interesting. This is from a real-world cohort that was presented here in ID Week this year. And really, if you focus on the left, on the reasons for choosing long-acting injectable treatments, this was specifically for cabopivirine. But on the left in green is the providers, the reasons why they were choosing to initiate cabopivirine. On the right in orange was the patients. And what's interesting is you'll see on the left there's tolerability, potency, decreased pill burden as the highest reasons for choosing long-acting injectables. On the right, for the patients, you saw more convenience, particularly when folks are traveling, and just to see if it's a better fit for them more generally. If you look at it a little bit closer, there's some divergences. What the providers think is actually at the very bottom of what the patients thought. So that's kind of interesting. And alternatively, what patients considered most important was at the bottom of the provider's list. So to me, that really points out that we as providers, we need to understand where patients are coming from. And maybe when we think about who's a good candidate, who's not, we need to think about some of these factors. On the right here of the slide, we have preferences. And we already know patients really, they have a high preference for long-acting ART. 93% in this cohort. And what I also found really interesting was this piece right here. Again, behaviorally, patients thought, they thought their HIV was better controlled, they had a better relationship with their provider, which I found super interesting, and they were more engaged in their care. All things that we want, right? Particularly if somebody's going to be on long-acting treatment. There we go. So Latitude, I'm going to start with Latitude. I kind of skimmed over most of the primary clinical trials in one of the first slides there, but Latitude was recently reported at CROI. And basically, this was a study looking at folks that were having a hard time with adherence. So just think non-adherent patients. Within this population, they defined folks with HIV with adherence barriers as those with viremia for the past 6 months on oral ART, or a loss of follow-up with ART non-adherence. And really what they did was folks had to be virologically suppressed by the time they got randomized to either standard of care oral treatment or long-acting with cabopivirine. And within that first 6-month period, they were given financial incentives, which is an important factor here, because if they did not get virologically suppressed by the time of randomization, they weren't randomized. But after that, step 2 was either cabopivirine or the standard of care. And then after the trial was actually stopped, which we'll find on the next slide here, and they were offered in step 3, or it was opened up to patients on standard of care. So, there we go. All right, so on the left, you'll see the primary outcome is actually regimen failure. And what's interesting is it was basically a composite outcome. So if you look at the 2 middle boxes in yellow there, confirmed virologic failure and treatment-related failure, which is defined as with drug-related AEs, so adverse events if they stop because of that. And with the primary outcome, it wasn't necessarily if you look at the confidence interval across 0, right? So it wasn't technically significant, but it was a reduction on the cabopivirine side of 15%. If you separated those out, that composite out into 2 separate outcomes, what you'll find is that there is an 18% difference and a 17% difference with less probability of failure and treatment-related failure for those on cabopivirine. And because of that, the DSMB chose to stop the trial early and allow folks that were on standard of care to choose cabopivirine if they so choose. So really, what do we know about the challenges? We have, in my view, we have two. We have clinical and we have logistical. The clinical, really to me, I mean, I'm a pharmacist, right? So I think about pharmacokinetics quite a bit in our lab. And the long pharmacokinetic tail is, it changes the dynamics of how we think about these treatments. And because of that, we got to think about who we should select for these treatments, or should we select at all, really? And so that's important to think about. And then you have special populations like pregnant persons. We don't really have a lot of good data of use of these drugs within that population, so that's a challenge. And then viremic folks, or folks with low-level viremia, particularly if they're already on gabapentin. And then on the logistics side, it's more about, does the site have the capacity to provide the treatment? Do they have the people? Can they do the billing and the coverage determination? Can they track folks to make sure they stay in care? And is it a sustainable, from a financial perspective, service? There we go. So let's start with the long tail effects here. So we already know that there's some associated factors with virologic failure, and this is down in the bottom left box. So you'll see those listed there. High BMI is a notable one. Some baseline mutations like the L74I and low trough levels for rilpivirine have been noted. On the right, what's interesting here is what this is looking at is from Latte 2 and Atlas trials, and they're looking at basically after the time of the stop of the last injection, how long does it take before the drug kind of eliminates, or what's that decay? So on the left, you'll see CAB. On the right, you'll see rilpivirine. And what you'll notice, this scale is 12 months. So basically, it takes a long time, right? And in some cases, if we were to expand this x-axis out even further, it's 2 to 3 years that drug's going to stay in somebody's body. So those terminal half-lives are quite long, and that is where we have concerns with drug resistance. So if somebody is, say somebody comes in, they get a shot, and then they miss the next one, and they're lost to care without durable ART, right? There's a risk of low level of ART with viremia, and that's a problem, particularly with selection of resistance mutations. So this is the resistance. I kind of adapted it from all the clinical trials here to kind of show you what it would look like. You'll see on the left all the major clinical trials for HIV treatment and prevention, and on the right I just tabulated into a graph so you can see what it looks like in terms of cumulative numbers. What's important to note here is that, and I think a lot of people forget this, but the E138K is actually in the integrase and the reverse transcriptase gene. So you have to, when you're looking at and it affects both sides of the equation. So when you are looking at a genotype, you have to look at which one that's particularly coming from. But the important thing to note here is that failure was low. It is pretty rare, honestly. But resistance did happen in some of these cases, and so it's important to recognize that does happen. So we have this shift in adherence based on what we think about oral ART, right? So it comes down to, instead of somebody focusing on whether somebody's taking a pill, we're observing somebody receiving a shot, right? So that whole factor of non-adherence is kind of eliminated. And now we're focusing on retention. Can we get the person back into the clinic to get their shots, right? So it's a classic risk-reward benefit, right? So if we look at the risk side, if we risk low retention, we have potential problems for viremia, and that could potentiate drug resistance. And that would be a problem, right? And again, it's rare, but it can happen, and we want to preserve all of our treatment options if we can. Alternatively, if we can keep folks in care, we have a lot of benefit to gain. So patients are super satisfied, improvement in outcomes, right? They're engaged in care. And from a financial sustainability standpoint for the clinic, we have to think about whether something is actually beneficial, that we're not losing money, so to speak. And so this can be a very good thing both for the clinic and for the patients. But the feasibility really comes down to the site, and the success really comes down to the site and the patient. So the focus is on retention. This is from some observational trials, 2 on CAB-LA and 1 on rilpivirine. You'll see the delayed injections here with the median in parentheses if it was reported, and missed injections on the right in the third column. It's important to look at this because to me, there's a clear difference in folks on PrEP versus those on HIV treatment. With HIV treatment, you'll see, generally speaking, based on this, just observation, you see higher rates of delayed injections on the PrEP side of things. So again, we want to minimize the amount of delays or missed injections that we have here. So this is where we have to come in and think about who is on the team. So really, when we think about oral ART, we're thinking about the patient. We write a prescription, they go get it, hopefully they go get it, and it's on them to take it, right? And we can provide all the adherence support that we can. But with long-acting, a lot of that adherence shifts to us too. And so we have to think about how can we help this patient succeed while they're on this treatment. So to me, these are my personal things that I think about. Multidisciplinary teams. Who's on that team, right? And who should be handling what role? Are we allowing flexibility in injection schedule? Do we offer transportation assistance? How about appointment reminders? Can we track somebody down? Do they have communication? All things that we have to think about before we start somebody on these medicines. So that leads us to this conundrum. We have patients that really want these medicines, and we have known logistic barriers that are quite high compared to oral ART. And sometimes that can lead to lower scale up of these treatments, which we want to make sure that if we're going to offer it, we're allowed, particularly if it's a very good agent, we want to make sure that patients have access to that. So I'm not going to spend too much time on implementation stuff today. I might do a little bit in the breakout session, but there's really, in my view, three kind of levels. So there's organization, site, and patient levels, and you see those listed there. And I'll talk about it here on the next slide as well. So I've given a couple of talks for IAS-USA, and if you've seen those, you remember this slide. But to me, I think of implementation as kind of a pyramid. In this approach, it's like how big the circle is, right? But to me, you got to start at the beginning, which is really, can you actually feasibly can you provide this treatment in a good way? So you got to do some site logistics planning, and then you got to think about, how about coverage? Can I get coverage for folks? And if so, how am I going to actually bill it? Is it going to be pharmacy? Is it going to be medical? Can I track the reimbursement? And then after that, you're thinking about, well, can I administer it? Do I have the staff available? And how do I track folks? And then you're finally to a point where you say, I'm really ready to start some folks on this treatment, right? And you start with patient selection. But implementation is really about planning, right? So if we're planning, we're doing it well, we have protocols in place, we got the right team members involved, and then we focus on retention and care. Once we start, we're gonna have a lot of treatment success. So really, to me, it comes down to three things. It's time, people, and money, or economics, really. So our team did a quick time requirements study to look and see how much time does it take us to manage somebody on long-acting versus oral ART. And you'll see that up on the top left. It's 3 times higher. So if you look at per patient per year, we're spending 9 hours versus 3 for folks on oral ART. And then the people, right? I've already talked many times about this already in this talk. Case management, billing, coverage folks. In our institution, we have coverage and billing together, and they're integrated into our process. You have your clinical team, so that includes your nurses for your MAs, and your providers. Pharmacy team can be in there, and pharmacy can provide a role not only clinically but also from an access piece as well. And then the money side of things with economics, it's really about making sure that you're not in a negative position. So it's all about scale and sustainability. Okay, so let's get into these cases. So case 1 is a adolescent woman, maybe not adolescent, 19, I guess. So AD, 19-year-old cisgender woman, vertical transmission, currently on BF-TAF, and has well-controlled HIV. They have Medicaid coverage. They travel to Southeast Asia 1 time per year, and it's a month long. They're not sexually active, and they're a freshman in college. So this person is interested in long-acting cabrolpivirine. So what do we think about? So I'm gonna go to my panelists here and just ask you guys, what do you think about when you're thinking about who's eligible for cabrolpivirine, or what is a good candidate? what do you think about? Go ahead. Yeah, I'll start.
Okay.
Dr. Chu. Yeah.
Great. This is what I get for being next to you. No.
Yes.
I mean, I think it's great. I'm really appreciating that she has, remained in care. I think the two big questions that come to my mind are just, okay, I need to go through 19 years of charts to make sure that I really have a complete treatment history, and then also look for historical genotypes. And then I think the second bucket is just sort of like planning for the unexpected. So I'm hearing that, there's pretty regular travel, and I think just I would want to drill down a little bit to know sort of, at a more granular level, how that might impact logistics of like staying in touch with this person, just stability of insurance, just for planning the injections.
Dr. Scott, anything to add?
Similar, and I think that she's raising this, which I think is pretty important. So I would want to explore more about why she's interested in it and where this is coming from. I think with a lot of my younger patients, it's because their networks are talking about it, because they're on it, and it does seem to support them staying engaged in care. So I think it's like a positive component for it. And then also she's a freshman in college, so I'm wondering, is that local or is that somewhere else? And are you going to have to work with her on breaks and those kind of things to get her injections?
The only thing I might add is that assume she's good about keeping her visits. I'd want to check her visit adherence, but sounds like a great candidate. In fact, the type of individual who I think are the best candidates are those who are interested but are also perhaps not on any other oral medicines. If people are already taking an oral medicine, just another pill in their pill box, but this may get her off of all oral medications, so I think it's a positive.
Yep. So these are just a quick table on eligibility and other considerations to think about with cabopivirine. There are some differences that you could throw on to this table for sure, but generally speaking, if you're looking at the package insert or definitely the package insert, but some in the guidelines as well, we're looking at sustained virologic suppression, meaning over 3 months, no treatment failure, no suspected or known resistance to either cab or ropivirine, and somebody over 12 years. I think for me, the thing that I think about is some of the stuff on the right. To me, the left is pretty clear cut. The right side is some things that we forget to think about. So particularly Hep B. So it's really important. I've actually had 3 patients now that have been started on cabopivirine, have been transferred into our clinic and had Hep B, but were not on treatment. And so I know that folks are getting started on this without that being part of the baseline stuff that we would do before starting somebody. So it's important that we check somebody's Hep B serologies to make sure we know what their status is. Again, with pregnancy, we don't really know a lot. We know some, but not everything about the safety of these drugs within that population. And then, of course, anyone that's on a fast metabolizing drug such as like rifampin or rifabutin or carbamazepine, there's a lot of them, right? Those medicines, both of these medicines are metabolized by 3A primarily, CYP3A, and so those are going to be excreted or metabolized a lot quicker. With a long-acting, it's hard to say like how fast, and of course there's differences in pharmacokinetics with different people. And then, of course, if we're going to inject in the gluteal area, if somebody has an implant or a filler, that could potentially change the absorption of the drug. So we have to think about that as well. And for me, what I think about, honestly, is, and what I've found is, patients' understanding of what they're getting into is really, really important. If you sit down for a little bit, say 5 extra minutes with that patient and just explain to them, this is what we're doing, these are the ramifications of this and that, this is the downside, this is the benefits, and then they have a good idea of what the risks are if they were to miss a visit, right? And we try to mitigate those up front if we can. So the case goes on. So she comes back 2 years later. She remains suppressed and retained in care. She's on cabopivirine, and she reports that she's 13 weeks pregnant. So AD believes that she would not stay adherent at this point to oral ART, and she'd prefer to stay on cabopivirine. So this is the first audience response question. So before I ask my panelists, I'll have you guys answer this. So how would you handle this? Let's see if I can get to this. There we go. So would you revise to oral antiretroviral therapy? Would you continue cabopivirine at the every 2-month dose? I didn't say that in the previous slide, but she was on every 2 months. would you continue with cabopivirine once a month dosing? Or would you do the 2-month dosing every month or something completely different? All right. It's interesting. All right. So what do you guys think? What would you do? I'm going to start with Dr. Chu again because she's right next to me.
So one of the positions I'm in is actually with the perinatal hotline. So, I'm hearing cases of just like sort of all across the board, reasons for, being on cabopivirine in pregnancy or not. So all that to say, a year ago, I might have really been like, oh, well, we really need to look at the PK in pregnancy and maybe there might be an advantage with every month. But honestly, today, I don't think we've got the data yet to say that one is better than the other. And I think, again, just reflecting on what this person's life is looking like, if they're suppressed on every 2 months, I would, probably lean towards that, but just with a next level conversation that, there's a lot we don't know, but if that's her preference and, she's already had the drug exposure, right, sort of early in the pregnancy. And so if this is really what she wants to do for the remainder of the pregnancy, I would be supportive.
Yeah, I'd follow that same guidance and use sort of shared decision-making. I think she's pretty clear about not wanting to switch to oral. I don't think we have, such definitive data that this is going to be harmful, and this is already at 13 weeks. So I'd rather her be on a regimen that she's excited to continue, remain virally suppressed. That's going to be one of the most important things for her birth outcomes, is remaining virally suppressed, and have her switch to something else that fails because she's not invested in it. And so I think that risk outweighs the risk of any pregnancy implications for this, given the stage that she's at now, and the fact that if she's virally suppressed, that'll be the most important thing.
I haven't looked at the PK data in pregnancy for this. I assume there is something. I talked to my neighborhood pharmacist and asked me what the PK looks like, which I'm sure you're going to show us in the next slide. My recollection is that the PK is affected, and I would lean, barring other evidence, towards advising her to go to the oral regimens that I know are going to work. And I think in the setting, I imagine that this story may be a little bit created for the purpose of the conference, but this is a young lady who acquired her infection perinatally, and I'm sure she doesn't want to continue to put her baby at risk. So I think I might have a heartfelt conversation in a supportive way and say, we know pretty sure that if we put you on oral therapy, it's only going to be for a short while. When you finish the pregnancy, you can go back, but I would lean towards going to oral therapy personally.
Yep. Yeah, I share the shared decision-making view as well. I think it's really important to have that discussion and make sure that you're not only talking about what they want, but sharing the risk and benefit of all options and making sure that they understand that. This was a real case. It's been adapted a little bit, but you'll see. Actually, I can talk a little bit more about what happened here in a little bit. So this is from the perinatal guidelines. So this patient would be fitting in the shared decision-making, that first light blue box on the right. You can see kind of what is recommended here for cabopivirine for people of childbearing potential. And really, I think in general, generally speaking, shared decision-making should be part of the discussion regardless, right? And so that's my view on that. And with regard to PK, we know a little bit, but not a lot. And in the trials, in the clinical trials, if somebody was to become pregnant, they were taken off of cabopivirine. And so this is a summary of the 25 pregnancies within this cohort. On the left, you'll see cab and ropivirine concentrations after they stopped. So you'll see in the trimesters, the gray is first, second is green, and the yellow is the third trimester. And really, you'll see a slow decay. So I think, to Dr. Chu's point, the medicine is still going to be there regardless, right? So at that point, the baby is going to have some exposure to the medicine, and so it really that needs to be talked about. With this subset in particular, some of these folks were actually put on boosted PIs, and so that is going to increase the concentrations a little bit, and you'll see that in some of these upticks in those concentrations. The birthing outcomes are on the right. So you'll see there's 40% were live births, 1 with congenital abnormality, and 15 non-live births. Half of them were elective abortions. But I think the key point here is there's a lot of variability. And what we know is a lot about rilpivirine and not much about cabotegravir. So on the left, I don't really particularly like this figure because it's too many colors, honestly, but you'll see the second, third, and postpartum in the columns there. But really, if you focus on the right, it's hard to see on the left, but on the right, you'll see that in the second and third trimester, compared to the postpartum timeframe, there's lower concentrations of rilpivirine. And so the problem, though, is what does that mean dynamically? Does that mean that that person's going to be viremic? We don't really know that, right? And so, but it's important to recognize that there are differences there. And particularly with rilpivirine, there's a lot of variability from person to person and even within the person. So that's important to think about. But definitely we want to make sure that at the end of the day, there's the person is virologically suppressed by when they're giving birth. All right. Case 2. So this is a 35-year-old cis man in prep care. They had been on FTDF for a couple years, and then they were interested in CAB-LA and decided to switch to that. And what you'll see in the top is some of the coverage determination that we had for their commercial insurance coverage. This person was set up on the ViiV savings program and they skipped the oral lead-in. And what's interesting is within the month, they came back in between with the next shot and said, hey, I changed jobs and now I don't have insurance. So what do I do? And this is a real life scenario, right, that could happen. So I think this is my next audience response question, so I'll have you guys answer. So what do we do for this person? Or what would you first, I guess? That's probably how I should phrase it. So would you evaluate their financial status, meaning their federal poverty level for patient assistance, transition them to oral prep agent, transition to oral CAB, or something else entirely? All right. That's what I would do too. So I'm going to give this one to Dr. Scott. Is that what you would do?
Yes.
All right. All right. So what are you thinking about in a case like this? What are you walking the patient through in that case?
It's just a mess. This is our healthcare system, and, we have folks who are being proactive and excited and interested in prep, and then we have all these ridiculous barriers in their way. So we try to, after I've tweeted the health insurance company and tagged the local commissioner of health, I would, which I actually have done in California, what I would do is work on figuring out, is there a strategy to getting this person access to the injections, to the medications through one of the patient assistance programs or through some prior authorization or one of our ViiV. So ViiV actually does have a lot of folks on the ground who can help with some of these and help with pushing some of these things through their ViiV assistance program. So I'd push hard on that. And then I generally do give most of my patients a prescription for generic FTDF if they can take it, just so that they have it, one, to cover gaps, but also when scenarios like this come up, this happens like all the time with privately insured patients. So I would really try to push hard to get and keep them on injectable if we can, and then give them a plan B and have a long discussion about how to manage it.
I agree. I mean, that sounds exactly right. The answer of transitioning to oral cab, I don't think helps that much because I don't know what the cost is, but I suspect that's equal, or maybe not, but close to it. And yeah, trying to find a patient assistance fund maybe through ViiV, and hope for the best.
Oral cab is actually pretty easy to get.
It
so
is,
when you
yeah.
order the meds, they actually will send you the oral cab like weeks or months before you can actually get the injection.
Anything else to add, Dr. Chu?
No, I mean, I think a lot, I mean, I agree. I mean, I have never tried to get oral cab. I think that's just me, not like, you know, sort of like that is logistics. But yeah, I mean, I think the other thing to think around oral cab is we have, I guess, limited experience about really sort of how to use it. And I think as a long-term plan, that wouldn't be ideal. And so that's when we would want to make sure that the patient does get approved to get onto LA cab. And I appreciate what you said about having that plan B, because life, you know, happens. And I worry about people who are transitioning between, you know, jobs or just life situations, you name it. And I would also feel more comfortable making sure that they had something as a backup.
Yeah. So one tip that I do, and maybe you guys do this too, so whether somebody wants the oral lead-in or not, I still order it for everybody. So that way they have a stock for them, and we use it for bridging purposes. The one downside to that is I found that the expiry on that supply that you get is kind of short, so it doesn't last for a long time. But I think I agree with Dr. Chu. I think there's a lot we don't really know about bridging with CAB, and I would probably prefer like a FTDF or FTAF alternatively. But I agree with everyone else in this audience, right? I think the first thing to do is to look and see if we can continue this person on CAB LA. And so going through the patient assistance route is probably the most feasible. So here's what kind of the overview for uninsured folks. So I added cabopivirine in there too, and lenacapavir just for comparison's sakes. But 500% on the federal poverty level is the financial requirements. You'll see the bottom, you can see it's based on dependent levels. So I just put 1 through 3 down there so you can see what that is in gross terms. It's also important to note that, particularly with the ViiV products, that if you have a Medicare Part D person, they will, if the person pays $600 of their donut hole, they will allow them to jump into patient assistance. Now, the caveat to that is there's some changes in the Medicare law, and so I'm not exactly sure how that's going to play out for 2025 and further, but right now that's how that stands. And then also citizenship is not required, so folks just need to live in the U.S. and they have to provide some sort of financial documentation or a letter of medical need. And then bridging-wise, I have a table on that just to show you what it looks like here. Technically, for CAB LA, you can use oral CAB or you can use an oral PrEP agent as a secondary option there. The restart on the injections is dependent on how long they have been bridging. The same would be true for cabopivirine, and you can use any suitable oral ART there. And then for Len, it's a little bit different. So we have a little bit of data from CROI, I think in 2023, using weekly dosing of lenacapavir for bridging purposes there. And then, of course, if you're past the 28 weeks, you have to reload them.
So a quick comment on lenacapavir, and that is that it's obviously not approved yet for prevention, although the data are out. The PROMISE-2 study results should be published soon, and I suspect the FDA approval will follow. What do you think, maybe by January? That's a guess, maybe a little longer, but you can't get insurance coverage for a drug that's not approved for that indication, so we got to wait for that one.
Yeah.
Yeah, it's being submitted. It's going to be actually submitted as a new drug, so that has a different name based on community input. Mm-hmm. So it's probably going to be 6 months. It's got expedited approval, so it should be June.
Okay.
And with regard to access for lenacapavir, it's a little bit different than the ViiV products. Particularly, there's a limited network, so you can't just, like, ViiV's network is very large. So if you went the pharmacy white bagging route, there's a large amount of specialty pharmacies that are included in there. For lenacapavir, right now as it stands, it's very limited to one, actually, if I remember correctly, and that makes it very challenging, right? My guess is that's going to expand. I mean, you would want that to be a much larger access network.
Oh, Dr. Havens, can I ask you a quick question? Could you just speak to the different oral lead-in schedules for lenacapavir? Like, is there a particular scenario that you might lean towards one?
Yeah.
Two specifically?
Yeah, I like the quick one personally. So there's two. There's option one is basically doing it in 2 days, and you start the lenacapavir on day one with the oral, and then day two you take oral lenacapavir as well. The more drawn out one takes 2 weeks, and I feel like it just the chances of somebody missing one of those doses is so much higher. I just feel like let's just bang it out quick and get it done. But both of those are listed as in the package insert as feasible options. I just prefer the first one. Yeah. And with the bridging drugs, so CAB itself comes from one specific mail order pharmacy. You just call them up and order it. And I've been told that you get 2 months free in a year. So there's that. And then lenacapavir is actually, you have to bill it as part of a pharmacy benefit. So really what happened to this person is they stayed on CAB-LA, and we told them you're going to have some sort of financial obligation, and they were okay with that. And they ended up paying $407 for the one patient assistance injection that they had. So you can see comparatively what it looked like compared to their other two that were commercially covered. But then it got weirder because then they changed their job again. And so then we had to, and they actually changed it twice. And so they were without insurance for quite a while. But the good thing is the patient assistance program is active until we tell them it's not. And so they were able to maintain CAB-LA throughout that time period. And they're doing great today. So, all right. And oh yes, this is really important. We also looked at our insurance changes in every year. 40%. We had a 40% rate of people that were on long-acting were changing their insurance in a given year. I don't know if that's what you all see as well.
Yeah, I mean, it's been quite striking to see with injectables rolling out, particularly for prevention, how much more difficult this is to get for people commercially insured than it is for publicly insured individuals, Medicare being a slight exception to that. But this is just happening like all the time. We have 3,000 patients in our clinic.
Yeah.
We can't keep up with the number of changes that's happening with CAB-LA.
Yeah, that's where it's really important that you have like coverage folks that's what they're doing.
Yeah.
Like they're just keeping on track with all that. All right, case 3. We got a 54-year-old cisgender man. They have had HIV for some time, since 2011. They started on efavirenz FTDF, transitioned to cabrilpivirine in 2017 as part of the randomized clinical trials. Their baseline genotype was pan-sensitive, and they have well-controlled HIV, been suppressed for a long time. Then they transitioned to commercially sourced cabrilpivirine. And what you'll see here in the box is their viral loads and any genotypes that were done. What's interesting is that the moment they switched to commercial drug, they had some low-level viremia. The problem here is that in the trials, the lab was different, right? So we could chalk it up as maybe a difference in assays, right? But we couldn't quite say that. So because this person stayed low-level viremic for some time, we did a proviral DNA genotype, and it was pan-sensitive as well. So next one for you guys, what should we do for this patient? A lot of options.
I think,
Okay, good. So I think low-level viremia is a tough one because, first of all, the patient was super worried because they had been suppressed for a long time, right? And they were kind of freaked out about what this meant for them personally. And then two, we didn't really have a good answer for them to say, why did this happen, right? You've been on cabrilpivirine for some time. So I'll open up to Dr. Saag. What do you think?
well, the last case was a mess. This one's a hot mess. that's a southernism for y'all from the north. We're going to talk about this in the breakout with me this afternoon, but low-level viremia in the 50 to 80 range, I don't get too excited about. The fact that he was undetectable prior to that makes me a little bit concerned. I wonder whether the lab changed their assay that was a little bit more sensitive, but regardless, the last value of 239 is the concerning one. Once a viral load goes above 200, then you worry that this actually is inadequate drug concentration and partial suppression. That's a good hallmark. In the case of somebody on oral therapy, it almost always is because they've missed some doses recently, and you can intervene with counseling, and usually just a conversation brings things back into control. This guy's been coming in, getting the injections, hasn't missed. I worry that the concentrations are less. He was on twice monthly, every other month, I mean. You could go to once a month, but at this point, my personal lean would be toward going to oral therapy. That's what I would try to get him to do, with a careful conversation about why. Obviously, this is not working. Could there be something interfering? We normally think about divalent cations, especially with oral therapy. There's theoretical reasons why that could be intervening or causing a complication with the integrase at the molecular level, but I don't think that's really at play. I would lean towards switching to an oral regimen personally. We could also repeat the viral load and maybe get it from a different lab and see if that's in it. But the 200 that's kind of a red line for me.
Yeah. Anything to add?
No, I think before I saw the last value, I would have sort of considered maybe moving to monthly to see if they would suppress, and maybe it was, because what we do is the labs, right, we're doing their injections, so you're at the trough level, so, perhaps you could stay above whatever their threshold needs to be with monthly, if the patient's open to that. But above 200, that's sort of a red line as well. I think I would probably recommend switching to oral, figuring it out.
Yeah, I mean, I'm glad you mentioned the repeat viral load. Honestly, I would probably do that and plan to maybe draw a resistance test, and specifically to ask the lab if they would do a plasma. I'm not sure that repeating a DNA genotype would offer too much change, and I think if I could get those expedited, I feel like I've got a little bit of time potentially to make a decision about the next injection, whether you want to shorten the interval or, continue every 2 months, and then raise the possibility of really needing to transition back to oral, because I agree the cutoff of 200 was just, puts the conversation in a whole different category.
And the other thing to point out is in this clinical trials, when there was breakthrough confirmed virologic failure, a lot of times that was associated with resistance mutations to the integrase, and that's a big loss for that patient.
Oh, and I was going to say, I mean, I don't do a lot of TDM in my own practice, but I think it is very interesting, and I'm not sure at this point what the role is of doing it, but potentially if you were thinking about getting it, if it might change, the plan one way or another, maybe it's another data point. I'm not sure because I don't do it.
Stole my thunder there. That's what I was going to talk about now.
Oh, I'm sorry. Okay, I'll welcome back. I saw it as A.
So we did that. We have good access to a PK lab here on campus, so we were able to look at this. What's interesting is you'll see the viral loads on top, and then the subsequent PK values there as well. For a couple things. Number one, we don't really know what threshold to use from a PK perspective. What we used in this case was 4 times the IC90. So even with that, they were still 2 times above that. So they were more like 8 times the IC90, which is really interesting. So with these values, would that change what you would do?
Well, I found it interesting
Yeah.
and kind of, to be honest, surprising that the levels are as good as they are. But at the end of the day, it doesn't change the fact that his viral load is now above
Yeah.
200. And I would have to call this virologic failure, especially if confirmed. And the longer we continue with that, it's a cumulative risk of developing resistance and then having a problem for him in the future with regard to what drug therapy he might be able to go to,
Yeah.
with the exception of lenacapavir, which still should be active.
Yeah, and I think that's the key point. We don't really know what the PK levels mean, right? Because number one, there's so much variability. It's hard to really say like dynamically what this means. But this variability is pretty wide. So particularly for ropivirine. So we also we looked at between patients that were controlled. So they're on cabopivirine to see like what's the difference in patient to patient. And you'll see those down in that box, 44 to 45%, depending on the drug there. And then within the patient themselves, from injection to injection, you see roughly 30% difference from injection to injection. So that's really tough to really say what does this mean, right? And I think that's the key point to take home. And also the threshold, we don't really know what to use, for example. But as you'd have it here, the moment we switched them to oral ART, they were suppressed. So, you can't win sometimes.
Well, would you retrial?
So that discussion has come up, but I don't know if they are going to go for it, honestly.
Yeah, I was going to say that because, that's the threshold we talk about with U equals U as well.
Yeah.
So they've now gone beyond the U equals U. And I think for a lot of my patients, having that conversation with their sexual partners is an important piece of that as well.
Yeah.
To consider.
And real quickly on proviral DNA genotyping, it's got a C3 recommendation on the guidelines, and really where it might be a value is for folks that are suppressed or have a viral load under 1,000. But it's not concordant with historic genotypes. So it's only 75% concordant based on some data. So you got to take it with a grain of salt, so to speak. For me, generally, if I know what historical genotypes are and what they've been on, I can kind of generally say, okay, if they're going to have resistance that I don't know about, I kind of know what it might be in there. But when I do a proviral, if it's something new that I didn't even know about, then I generally take that higher on my list. But if nothing's there, I can't do anything with that. So hard to say the true value with this. All right. So transfer patient number one. We got two of these. So this is a 76-year-old cisgender man transferred to our clinic. They're on cabopivirine since 2022, diagnosed in 2012. Have some comorbidities, so they have hypertension, hyperlipidemia, some allergies, asthma. You can see their medicines listed right there. Nothing of DDI concern. The regimens, you can see those over time, what they have been on. Some interesting regimens, so to speak. So the patient reports some history of resistance, and the records requested from the provider, the old provider. So this is what we found. So the genotype from 2013 shows some non-nuke resistance, so a 181 and a 101. You'll see the Stanford database general printout right there underneath it. So there's a high level resistance to ropivirine. So the question is, this person is suppressed, so for 2 years on cabopivirine, but we now know that they have some historic resistance. So the question is, what should we do with this person? Do we leave them alone, or do we revise their ART? So this is for you guys. Yeah. And then I'll ask you guys. Yeah. All right. So what do you guys think? I'm going to start with Dr. Saag.
Well, I feel really old right now because I'm kind of scratching my head saying the audience really likes to leave him alone, and I want to change it. I'm with you on the wanting to leave them alone, but in essence, if we're going to believe that archive virus exists, which I think it does, there's evidence for that, and then we know that it's kind of a chance phenomena whether one of the viruses that a cell could happen to spit out might have a resistance mutation for rilpivirine because it exists. In fact, I would say that during that time of virologic failure when the Y181C mutation came out in 2013, that repopulated a lot of his reservoir with rilpivirine resistance. To me, it's a time bomb situation with him in essence on cabotegravir alone. So the question I would ask those who want to leave him alone is, would you feel comfortable just putting him on cabotegravir only and moving forward? Because the resistance to rilpivirine is binary. It's not like PIs where you have a little bit with just one mutation. This one Y181C mutation is 100, well, it's resistant. I mean, it's not going to be a little bit active. So it's in essence like we're just kind of giving him cabotegravir alone. And you will get a response to cabotegravir alone for a period of time, but he's at risk from this time forward for resistance to emerge and failure of the cabotegravir, which carries forward into dolutegravir and bictegravir. So I would just have if he really wants to dig his heels in and say, no, I understand the risk, I'll continue, maybe I'd continue, but I think this is another way of thinking about it, as if you had that data, those data in 2022, would you have started him on rilpivirine? And I don't think most of us would. So I think we should give him a chance to maintain his susceptibility to integrase inhibitors and say, sorry, I'd take you off. How'd I do?
I'll tell you what happened, but I want to hear you guys' opinion.
Okay.
Yeah.
Initially I was like, this gentleman is 76 living with HIV, like, let's just leave. But I think, actually, Dr. Saag is raising excellent points. I think there are very few people in the U.S. that are excited about the idea of INSTI monotherapy. I know that they've looked at Dolu monotherapy in some European studies, but I agree. I think that this person's extraordinarily lucky, and I would be worried in the back of my mind that it's just going to be a matter of time that I will see breakthrough viremia. To me, I think this might be a good scenario to maybe talk about adding on lenacapavir if going back to orals feels like a step backwards for the patient.
Yeah, I'd sort of agree with that, and I think having the discussion around what the risks are and how strongly the person feels about, patients who are on injectables do feel strongly about staying on them. So, I think that he will raise likely an argument that it's worked for 2 years. Like, why do I suddenly have to change it? To Dr. Saag's point, yes, if this had been present at the time of initiation, we would have said you're not eligible for it. And so I think it's going to be a difficult. So I would consider leaving him on it and then maybe monitoring more closely than I would have otherwise. I don't know if we're going to talk about lenacapavir, but lenacapavir does not have the same tolerability profiles as rilpivirine. Those nodules are real, and they're sometimes very large and very red. So I think that I would not necessarily jump to adding another injectable on top of that.
Yeah, we ended up just having a conversation with this person, and they wanted to stay on injectable treatment, and so we ended up adding lenacapavir, and I think, what'd you call it, the scream room?
Did you drop the rilpivirine?
We left it. Yeah. So that's, I mean, there's discussion on that too. Yeah. But
I feel like
remains suppressed, so all good.
Take cover.
So you're right. I mean, if we had known this information, we probably wouldn't have started this person on rilpivirine anyway, right? So there's that. And I think this really brings up the importance of getting the history. Make sure you understand what somebody's been on, what they might have archived back there in the background, and if there's access to getting genotypes, then we should do that. Monogram, if you call them, they will help get you those genotypes. So that's really important to go get them if you can. And I've listed here the San Francisco, or the Ward 86, just the snippet from the mutations that they exclude for rilpivirine. You'll see those there. Both of the non-nuke mutations are listed on that. And then just real quickly, this is from Croy. There's some groups have added Lin on top of cabopivirine and some with cab alone. And you'll see they had separated into groups. I just snipped out what was relevant for this case. But overall expression was 94%. That's great. So I looked to this morning, and I think there's a trial that is going to start enrolling soon, I think. It might be in Europe. All right, transportation number 2. I got 1 minute. I'm going to try to get through this because this is a good one. So this is a non-binary person. They came from a different state, diagnosed in 2018. They were on dolutegravir lamivudine for a while, switched to cabopivirine, got 2 doses, and then they were off ART. They relocated to a completely different state, then was incarcerated for a minute, was put on BF-TAF for a month, and then they show up to you off ART. So we want to know, they're presumed viremic. They want to start medicine today. They want dolutegravir rilpivirine or dolutegravir lamivudine or cabopivirine today. So this is for you guys. Real quick. And then I'll tell you. So what would you do? Would you start cabopivirine, dolutegravir lamivudine, go to boosted darunavir and F-TAF, or BF-TAF? All right. Nice, BF-TAF, okay. So here's what we found. So when we called Monogram and got his genotype, and this is what we found. So they have both integrase and non-nuke mutations. You can see the Stanford printout here with intermediate resistance to both. I think it's really important here to just kind of make sure you understand that if somebody comes into you with a history of cabopivirine in the past, and it's been months, they probably likely have drug there, right? And so the likelihood of them potentially, or the virus selecting for mutations in that scenario is pretty high sometimes. So it's kind of the worst storm if they've been off ART. So you got to think about that if you're choosing a regimen. BF-TAF with a 155 would probably work if they're adherent, right? But this person has a history of non-adherence that's going to make it challenging. So what we didn't find on there was PI mutations. So in this case, you could do boosted darunavir and F-TAF and be fine. If you're going to go with dolutegravir, do you need to do twice daily? You got to think about all these things, particularly if you're in a rapid start situation. And what about adjunct agents? So with that, I'm going to stop. And if you guys have cases that you want to bring up, if you're coming to my session later on, I'd love to talk more about it. And just see if we can help out in any way.
So we do have 10 minutes for Q&A right now, 15 minutes for Q&A. So if you have any questions, cards, why don't people stand at the microphones? It would be so much more efficient, especially if we get a big stack of cards. If you have a question about using long-acting agents, it sounds like there has been a lot of controversy here. And I think, Mike, I'm only very slightly younger than you, but I think we had that fear when we used to see people failing regimen after regimen with all those mutations that, like, we want none of it. And I think people today have just had so many patients that have done so well for so long and haven't had that awful experience of dying because they're resistant to everything that we went through. Yeah. Mic on it?
Just keep talking. It'll come on.
In regards to using long-acting cabotegravir for PrEP, and then for some reason they can't get it, their insurance, they don't qualify for financial assistance, and they're going to be off it, and you put them on something that maybe they can afford or something that they have access to, like Truvada, would you need to put them on it daily for a certain amount of time to get that cat tail out of their system, or can they use it on demand from the beginning?
Let me take it.
I'm happy to answer it too.
Go ahead.
So
I'm going to
for
repeat the question.
so the question was, if someone is on CAB-LA for prevention and then they lose access for some reason, and you switch them to TDF-FTC, can you use on-demand dosing I'm assuming this is a cisgender man who has sex with men, as opposed to daily and cover the PK tail. So what I tell my patients is, I'm not worried about the tail, I'm worried about you having prevention. And so on-demand, we give on-demand PrEP for individuals because we're protecting them from HIV acquisition, not the drug. We're more worried about their HIV prevention support than protecting the drug. And so you can do on-demand. It's not about the tail so much as it is about preventing them from acquiring HIV, which on-demand PrEP has high efficacy for.
This is on, yeah. I share the same opinion. I think it's really about the patient just really understanding that they need something, right? And whether that is on-demand or daily treatment or PEP, you know, we just need to make sure that they understand that they have options to go by. But yeah, that's tough.
Okay, we're getting lots of questions, a lot about if someone is late on dosing, like how late are they on their dosing? When do you know, around that, like if they're every 4 weeks or every 8 weeks and they're how many weeks late they are, do you worry about doing resistance testing and other things? When do you tell them to start taking oral agents if they can't get in? Like some of that practical matter around that issue?
Yeah.
This is for treatment,
Yeah, okay. That's tough, right? But we don't really know that answer, really. If you look at so here I am going to TDM data, but if you look at the PK data, like it doesn't, there's a huge amount of differences, right? But you're still going to have some protection there. I mean, beyond the post 7 days, it's just a matter of are you gambling, right? And I think in a lot of cases you might be. So for most patients, I generally, if we know they're going to be out, or if they call on day 8 and they're like, I'm not going to be in for X amount of days, I'll try to get them oral meds like immediately. Yeah.
And there's I'm
I
sorry.
won't let them drag out, I guess.
Okay, there's also a question about, oh, good, we have someone at a mic. Please go. Keep talking.
Alone or long-acting rilpivirine alone for treatment. For example, I have a patient with pan-INSTI resistance who I have on lenacapavir and cab rilpivirine, but the cab's not really doing much. Just curious if you know of cases of using just the cab or just the rilpivirine for treatment. Thank you.
I mean, I've got one patient that's essentially on rilpivirine, lenacapavir, and this person was, you know, getting very, very, very sick, advanced untreated HIV, and sort of we were heartbroken, right, to see how much INSTI resistance had developed, and just was like we were, between a rock and a hard place. It's nerve-wracking. I don't know what to say beyond that, but I think with the just getting more case series out there, maybe getting this trial, we will hopefully get more experience with what it looks like to have someone on lenacapavir and rilpivirine.
So do you give the shots? Did you give the cabotegravir then? Oh, so you just discard it? Okay.
Okay, do patients require an oral lead-in today?
What's that again?
For treatment, for long-acting, do you still do oral lead-in?
We always offer it. Most patients pass on the oral lead-in. It's really a preference thing. I mean, I would say 99% of folks just skip the oral lead-in, but we do offer it.
Okay, and there's a lot of questions about different BMIs, like a BMI over 50. Is failure all related to BMI, and some of the questions about the long needle versus not you might want to talk about?
Yeah, it's associated. It's association, right? Not causation. So BMI. I mean, technically, larger body habitus. The depot itself, it's harder to get to the muscle, right? And that's where we want it to go. So if you have a larger BMI greater than 30, in particular, you generally want to use a 2-inch needle, which for some time those are on back order and they're hard to get, so that's a problem, right? But even then, there was a study where they did MRI to look at like where does the depot go, and I think if I remember right, 50% of doses didn't even hit the muscle in like perfect situations. So there's a lot really we don't know. I mean, I'll say we have a bunch of patients that are over 30. We use 2-inch needles and they're doing great, right? I think it's just, ultimately it comes down to the viral load. If they're suppressed, they're suppressed.
And what about if they have implants in their buttocks?
I might let you guys comment. I have not had that come up, so I don't.
Yeah, we have that come up quite frequently. We have quite a few trans women in our clinics, and it's a variety of implants, fillers, lots of different types of things that people can have. And I think the most important thing is to examine, identify places. We have definitely been able to give non-ventrogluteal injections based on where the distribution of those fillers are. And then sometimes we will actually do a CT scan to see if there is a pathway to be able to give an injection for someone, because there's such a strong desire for someone to be on it, and we really think that they would benefit from it. But the assessment is really important. There was a small study that looked at thigh injections, and the PK seemed to be compatible with doing that. The patient-reported outcomes were not as good as ventrogluteal, but those were also in patients who had already gotten ventrogluteal injections, so we don't know in a naive population if that's what he's saying. But they're going to hurt. And so, those are something that we haven't done yet, but we're considering doing.
Okay. There are a bunch of questions about hepatitis B. So in the patients you get who have been switched, who do have hepatitis B, what have you done, or what should be done? Should they be switched to a different HIV medicine, have hepatitis B treatment added on top?
Yeah. So I listed it as a consideration. To me, if somebody still wants to continue with cabopivirine, that's fine, but they're going to need oral treatment for hepatitis B, right? And so they need to know that. Now, that conversation is a shared decision making, right? Because you could easily just give them BF-TAF if that's a good option for them, and they could you could do both in one. So alternatively, you might have like the person one of the people that I mentioned earlier. I've had both ways. I've had people that say, I want to stay on cabopivirine and I want F-TAF for Hep B. So we've done it that way. It's not like perfect, but it works. And the two other folks, I think, they actually switched to BF-TAF. So there's no right answer, but I don't think it's exclusionary for long-acting. You just have to know, so you're treating them accordingly.
I'll address some nuances of that tomorrow in tomorrow's cases.
Oh, great. Okay, so there was another question just about someone who is hepatitis B core positive antigen. Same thing.
Yeah.
Okay, yeah.
We'll do that
There's a lot of questions about that. So what is the rate of failure for people that are getting on-time dosing every 8 weeks, like at every 8 weeks?
Oh, I don't know the actual, do you know?
Well, I think the failure rates were really minimal in the original trials, but I think as more folks are publishing the sort of real-life experience with it, we might see some slightly, different ranges. I think that's my quick answer.
On time? It's pretty rare.
Yeah. It is extraordinarily rare. But again, I think we don't know a lot around the individual variability, and so it's like I haven't seen anything that says it's zero, basically.
Mm-hmm.
Okay. And so there have been a couple of questions about if you don't, I guess some people in the room, or there's several questions really about people if you don't have their entire history, resistance history, and if you could just explain what when you talk about archival resistance and what that is and how your ordering out monogram does, is you could sort of take a minute and a half and explain that, since there are a bunch of questions.
I may take that. So when somebody is first infected with HIV, the virus goes in and then replicates and fills most of the lymphoid space with cells that are carrying whatever the original genotype was. Very often that's wild-type virus, which means it's going to be pan-susceptible. If somebody goes on an antiretroviral regimen and that regimen fails, at the time of that failure, the virus that becomes predominant is now the virus that has filled a lot of that lymphoid space. So that when you move on to the next regimen, virtually all the viruses that are being expressed at that moment in time have the resistance mutation. So if it's a Y181C or whatever, M184V. So then when you go to use your next regimen, and it's suppressed, the virus, that means by definition that regimen is not affected by the pre-existing mutations. If later on you go back and want to cover or change a regimen, say somebody had a M184V in the past, they've been covered with, say, bictegravir-TAF FTC, which works in a case of M184V, but now you want to, quote, simplify, to dolutegravir 3-TC, with a history of an M184V, you run the risk of that M184V mutation being, in essence, using monotherapy, just dolutegravir alone, because the virus that might be trying to escape has the M184V. So just like you would never want to use dolutegravir 3-TC in somebody at the time you know absolutely has M184V, you wouldn't use that regimen. The same rule more or less applies because of the virus being archived in the lymphocytes and has the ability to escape at any moment. So that's generally the way you'd think about it biologically.
Great, thanks so much for that. It gets a little complicated, and there aren't good data about the use of archival. So we're out of time. Just one last comment. Someone said that the FYI that ViiV has a program for home injections of cabrylpivirine and will do home lab draws. That sounds amazing. Anyway, on that note, thank you very much. It's been a great session. We have a 20-minute break, and at 4:25 to go to your concurrent breakout sessions. Please make sure you've signed up before you appear, as the rooms can get overcrowded. Thank you so much.